Lakes, golf, baseball, lakes, camping, mosquitoes, lakes, ticks, mosquitoes, and fishing. These are all things that define Minnesota and Wisconsin as two of the best places in the country, at least for part of the year. But I can't complain. I love living in Minnesota. Our perpetual sibling rivalry with Wisconsin, the ridiculous extremes in our seasons, and the endless opportunities for outdoor recreation. Trust me, I lived in California for 4 years during medical school, and the grass ain't always greener. I'll put the Gophers and the Badgers up against any other state when it comes to variety and quality of life. But this also means we have creative ways to hurt ourselves, which gives all of us some form of job security. This month, we'll talk about trauma team activations, drownings, and bring you the latest Regions EMS news and updates. Turn down your radios and put yourselves out of service for the next 15 minutes, because I'm Dr. Peterson, this is Regions EMS Update, and those are the 3 things you need to know. In order to stay consistent with Regions Hospital's trauma guidelines, we recently updated policy number 115, the pre-hospital alert criteria. I think most of you have a good feel for when to call a trauma team activation, but just in case, let's review. Paramedics are able to call a TTA from the field when one or more of the following signs or symptoms are present, or when the medic feels that the patient is unstable due to their traumatic injury. We are also confident that EMTs are able to recognize severely injured patients, but in this area, you will almost certainly be transferring care to an ALS provider before arriving at the hospital. If you find yourself without ALS backup, you can always contact medical control to help with your decision. Here are the Regions Hospital trauma team activation criteria as they stand today.
Victory is mine!
Traumatic cardiac arrest, airway compromise related to trauma, sustained systolic blood pressure below 90 millimeters of mercury, GCS of less than 14, transfer from another facility with blood transfusion in progress related to trauma, flail chest or other major chest injuries, depressed skull fracture, focal neurologic deficits related to trauma, abnormal abdominal exam, major extremity vascular injury, 2 or more proximal long bone fractures, amputation proximal to the wrist or ankle, major penetrating trauma to the face or head, penetrating trauma to the torso, such as a gunshot wound or stabbing, burns of greater than 20% second or third degree, high voltage burns, significant burns with trauma, or an inhalation burn requiring airway support, pediatric hanging, physician judgment, EMS judgment. So what's the common thread across all of these criteria? The point of a trauma team activation is to get the hospital ready to perform an emergent surgical procedure. This is a very important point. We don't activate the trauma team just because the patient is sick. We do it so that we can have a surgical team prepped and ready to go. We've had crews activate the trauma team for things like unstable GI bleeds and suspected aortic aneurysms, but the reality is that it's often best to not invite too many cooks to the kitchen when most of them don't have a pot on the stove. Yeah, I just made that up. My point is that unless it's related to trauma, it's probably best to just ask for an ED stateroom and leave the trauma train in the station.
I'm Michael McGonigal. I'm the director of the Level 1 Adult and Pediatric Trauma Programs here at Regions Hospital. I'd like to spend a little time taking you behind the scenes of what happens during a trauma activation. You see a limited portion of that when you drop off the patient, but I'd like to tell you a little bit about who's there, what they're doing, and the criteria that we use to try to figure out who should be a trauma activation. I will also tell you a bit about what sets a Level 1 trauma center apart from all of the other hospitals, and I'll wrap up by talking about how important it is to make sure that you activate this team appropriately. I'm here in the trauma bay now, and you're not. So how did I get here? I'm not psychic. And what's happened is you have relayed a report to the MRCC, and they will in turn activate our trauma team. And there are several pieces to that. First of all, there's an overhead page in the emergency department because some of those team members live here in the ED. Many of the team members live outside of the emergency department, including myself. I'm usually somewhere else in the hospital. So there's an overhead page there to the whole hospital. And then everybody wears those old archaic pagers that you see everywhere. And those go off as well, so that if we're out of earshot, we end up coming down here. We have just mere minutes to get down here so we can assemble, brief the team on whatever information that has been relayed to us through MRCC, and then finally you come strolling in the door with our patient. 90% of the patients that you bring to us are blunt trauma, meaning that we don't have to whisk them right off to the operating room. So usually the next stop is CT scan and diagnostic imaging, which is the new fashion term for radiology. Typically, if we don't have to do a lot in the trauma bay, because we have such a big team, we can get everything taken care of in about 15 minutes and shoot over to CT scan. That way we can look deep inside every patient, figure out exactly what's wrong, and then develop a plan after that as to whether or not we need to go to the operating room or not. I'm standing outside the operating room area, and this area is notified of trauma activations just like everybody else. And they prepare by making sure that we have one room that is set up completely for an emergency trauma case. Now I mentioned that 90% of our injuries are blunt, but 10% are penetrating, and a smaller percentage of those end up needing to come straight up to the operating room. We can typically do that within 8 minutes of when they come in the door, and you get the surgical team as well as the OR team all converging. The emergency department team will deliver the patient to this area, but then they back off and let us do our work. Now this is a level 1 trauma center, and what that means is that we're kind of at the top of the food chain. We have the capabilities to do absolutely anything that can be done. Level 3 hospitals are around and they have basic trauma services. Level 2 hospitals are very close to a level 1, but they don't have research, they don't have residents, and they don't have some of the high-end specialties like reimplantation, open heart, and things like that. So if it can't be taken care of at a level 1 center, they go up to the level 0 center, if you know what I mean. So hopefully I've been able to give you some good information and a little insight as to what happens behind the scenes when you drop off those patients for us, and we appreciate all the interaction and look forward to continuing to work with you.
The twist to this story is that not all trauma patients need surgery right away. What I want you to notice in the list of TTA criteria is that none of them are based on the mechanism of injury alone. All of them have some physiologic or anatomic reason that predicts whether or not the patient might need emergency surgery. Doesn't matter if it's brain surgery, general surgery, or orthopedic surgery. What's amazing is that with today's engineering and safety standards, many people are able to walk away from horrific accidents that leave their vehicle mangled and splayed across the roadway. Although there is a greater level of concern with these types of accidents, our trauma team activation criteria depend 100% on your ability to perform a careful and thorough physical exam. If you've been involved with EMS for more than a few years, you've probably had a call for an accident that no one should walk away from. And yet you have a perfectly alert patient who looks like, at worst, maybe fell off their bike. You know what? We trust you. There's always the EMS judgment criteria that allows you to activate the trauma team if your trauma radar, or traumadar as I call it, starts beeping. But can I guarantee that you will never be questioned or second-guessed on your decision? No, but your job isn't to make the ED happy. It's to do the right thing for the patient. Your medical directors will back you up every single time if you are acting in the best interests of the patient. TTAs are called based on the anatomic and physiologic criteria mentioned previously. They are not called based on mechanism of injury. Mechanism of injury may mandate that the patient be transported to a trauma center, but mechanism alone does not necessarily warrant a trauma team activation. There may be times when patients have significant mechanisms of injury but appear to be stable. If you feel that a patient is a candidate for evaluation at a trauma center, then you should bring that patient to a trauma center. I would encourage you to review our trauma triage and destination plan in the references section of our patient care guidelines. This divides trauma patients into Tier 1 and Tier 2 categories. Tier 1 patients have either physiologic or anatomic criteria and should be transported to a Level 1 trauma center. Tier 2 patients have a significant mechanism of injury, but none of the Tier 1 physiologic or anatomic criteria. These patients need a good trauma exam, but are much less likely to require emergency surgery. Tier 2 patients can be taken to an appropriate Level 1, 2, or 3 trauma center, as Level 3 and higher requires proof of surgical readiness, just in case, in both Minnesota and Wisconsin. And the final point, don't forget about the trauma team timeout. This is an important transfer of information that allows everyone in the trauma room to process the information that you've worked hard to collect. Check this out.
The TTA timeout protocol helps to provide a safe and effective handoff from pre-hospital personnel to the receiving trauma team. The procedure is as follows. First, the medic arrives with the trauma patient and announces TTA timeout in the trauma bay, at which time everyone is quiet and gives their attention to the EMS provider giving the report. Next, the patient remains on the transport stretcher during the timeout, except in cases where CPR is in progress upon arrival to the ED or any other condition that requires immediate life-saving intervention. All urgent care, such as ventilation, will continue. Next, the primary EMS provider gives a verbal report to the leader of the trauma team in the commonly used MIST order. M stands for mechanism, I stands for injuries identified, S is symptoms, which includes all vital signs, GCS, and pupil exam. T is treatments provided. And then finally, the EMS providers will ask if there are any questions. The patient can then be transferred to the ED stretcher. Pre-hospital providers then exit and the trauma team takes over.
All right, everybody, this will be a TTA timeout. Mechanism, we have a 26-year-old male involved in a motor vehicle crash who was entrapped. Extrication took about 11 minutes. Driver of the second vehicle was deceased. Injuries include a right femur deformity and midline bruising. He has abrasions to the left forehead and face, as well as to the bilateral forearms from the airbag. Signs and symptoms, ABCs were intact, but patient was unresponsive. Initial vitals were blood pressure of 88/56. Pulse of 96, O2 sats of room air were 84%. Initial GCS was 8, with shallow and clear respirations at 8. Pupils were equal and reactive to light. Treatments included patient being RSI'd without complication, 16-gauge IV to the right AC, as well as a IO to the left tibia. Hair traction was placed on the right leg with good CMS. He's received 900 mLs of normal saline en route and administered 10 milligrams of IV morphine. Any questions?
No, thanks. Nice job.
All right.
All right, let's get him over here.
I hope this helps to clarify some questions you may have had regarding trauma patients. If things are still not clear, you can refer to our guidelines, Policy 115, and the Trauma Triage and Destination Plan. Or you can email our office at emseducation@healthpartners.com. This episode marks the 2-year anniversary for Regions EMS Update, episode 24. We've covered a lot of interesting topics, but part of our intent is to provide timely and relevant education on topics that might not otherwise come up. Let's dip into our archives to review a segment we did on drowning and submersion injuries back in 2017. Many moons ago, I had a summer job as a lifeguard. I guarded the heck out of Long Lake Beach in New Brighton and ended the summer with a grand total of 1 save. Fortunately, my saves outnumbered my losses, and the whole experience ignited a passion for emergency care. My journey has brought me full circle back to the water today as a board-certified EMS physician. Unfortunately, my legacy as a lifeguard is not finished, as we continue to see drownings and other water emergencies throughout our service area. Minnesota and Wisconsin average 40 to 50 drownings per year over the last several decades without any real improvement. These incidents are often very emotionally charged, and there are usually plenty of people around willing to help, for better or for worse. Realistically, if the victim isn't out of the water by the time you get there, the chances of a good outcome are pretty slim. Everyone wants to cling to stories of prolonged submersion, but the reality is that after 10 minutes underwater, the chances of survival drop off dramatically. If you happen to be part of a water rescue, there's a guideline for that, and here's what you need to know. First, assess the victim's mental status. A normal mental status is reassuring, but it's still important to encourage the patient to go to the hospital for a period of observation. Delayed respiratory problems, such as pulmonary edema, can happen up to 6 hours after submersion, so typically we watch these people for several hours in the emergency department. Next, assess the victim's breathing status. If there's any sign of respiratory distress, be prepared to provide assistance with positive pressure ventilation from either a CPAP or a BVM. Freshwater drownings tend to cause atelectasis. This happens when the inhaled water washes away the surfactant, or the fluid lining the air sacs in the lungs. This causes the air sacs to completely deflate and takes quite a bit of effort to pop open again, kind of like how the first breath is harder when you're blowing up a balloon. Fortunately, we can help with a little positive pressure ventilation. This would be a great time to dig up the PEEP valve that attaches to your BVM. Another decision that causes stress is when to forego resuscitation efforts. Even though 10 minutes is a realistic survival timeline, our guideline uses 60 minutes as a rule of thumb. Beyond an hour of submersion, the only time it makes sense to attempt resuscitation is if there's visible ice on the water or if the victim is a child. Survival after a lengthy submersion is mostly dependent on how fast the victim cools to hypothermic temperatures and the resiliency of youth. One of the difficult decisions we make in EMS is deciding when our efforts are futile. Guideline 62, our Drowning and Submersion Injuries Guideline, gives you some parameters on when to shift a rescue effort to a recovery effort. I would encourage you to review this guideline and never hesitate to involve medical control early on to help you decide when the risk to the responders becomes greater than the chance of survival. I'm Dr. Peterson, and this is a Regions EMS update. Last month, we talked about a research project looking at trauma team activation criteria called the Inception Study. Well, this didn't roll out as smoothly as we had hoped, so the plan has changed a bit. MRCC will not be asking you which criterion you are using to activate the trauma team. Instead, a research intern will meet you in the ED after you drop off the patient and have you select the criteria from a list. This should be a lot simpler and less disruptive for you. I would encourage you to review the updated TTA criteria in our current guidelines to stay up to date. So what's up with medication shortages this month? I don't know, let's spin the wheel of randomness and find out. Looks like nothing new so far. Between D10, switching from preloads to vials, and creating a mix-your-own epi kit, we've been able to navigate the daily pharmaceutical struggles up to this point. Now we just cross our fingers and check in again tomorrow. Lidocaine has been added to our cardiac arrest guidelines as an option if you don't have access to amiodarone. But amiodarone will still be the first choice for shockable rhythms when it is available. We've been talking about aspirin documentation for several months now, so let's look at the data and see how you all are doing. Kudos to Maplewood, Lakeview, and White Bear Lake for moving the needle up a bit. Still not at our goal of 90%, but performing well above our system-wide average. Remember that we need aspirin documented in the medication section of your report, not just in the narrative. If the patient refuses or already took it, note that in the comments box for the medication or use the appropriate checkboxes in the medication section. Remember that for our quality assurance purposes, checkboxes collect data and narratives paint a picture. Both are important. I'd love to hear some ideas any of you might have on how to remember to document aspirin. Maybe a sticker on your cardiac monitor, a reminder in your PCR app, or some competition between shifts or stations at your agency. Let us know at emseducation@healthpartners.com. And finally, It's the end of another era at Regions EMS. July 1st is the traditional changeover date for physician training programs, and with that, we bid farewell to Dr. Elizabeth Robinson. Dr. Robinson has finished her training with us and will be starting her career near Madison, Wisconsin, spreading the Regions EMS Kool-Aid far and wide. In addition, there is another friendly face you won't be seeing in the ED anymore. Believe it or not, Dr. Frasconi has worked his last shift in the Regions ED and has passed the torch onto the less seasoned physicians in our group. Don't worry, he's still active with EMS, but maybe some congratulations are in order next time you see him. Well, that will do it for this studio update, but before we go, I'll leave you with this. Another day, another dollar. Or for many of you, another day, another 24-hour shift away from home. Hey, take advantage of your days off. Have fun with your family, enjoy the upper Midwest summer weather, watch the Twins pound out 5 or 6 home runs in a game, or relax on your porch. Do something to rejuvenate your soul so that you are ready to bring your A game when you're back on duty. If any of our videos have been helpful to you in any way, please let us know so I can let my boss know that I'm being productive with my time. And as always, thanks for watching this month. We always appreciate a quick email or a suggestion for a future topic, so hit up any of our social media sites. On behalf of Regions EMS, I'm Dr. Peterson. Stay smart, stay safe, and stay professional.